Hello, everyone. Good afternoon, and welcome to Doc Talk. My name is John Moore, and I'm the Director of Development for Providence Cancer Institute. I am thrilled to have you with us here today with Dr. Christopher Darus. He's the Medical Director of the Providence Gynecologic Oncology Program and Clinic. Today's presentation, Gynecologic Cancer in 2022, Victories and Challenges, is part of a virtual speaker series called Doc Talks. These presentations bring our best and brightest clinicians and researchers to you, so you can learn more about how revolutionary treatments, research, and community-supported efforts fueled by philanthropy are bringing hope to more patients throughout Oregon and the region. At Providence Cancer Institute, our research focuses on harnessing the power of the immune system to fight cancer. Thanks to advances in genomic sequencing, we're bringing together the power of immunotherapy and personalized medicine to accelerate leading-edge research and groundbreaking discoveries for patients with cancer. We conduct a range of investigational and combinatorial clinical studies through the Earl A. Childs Research Institute, a division of Providence Cancer Institute. At any given time, we have over 400 clinical trials in progress, including many that are led by our own researchers, single patient experimental trials, and first-in-human trials. Our patients are 5 times more likely to be enrolled in clinical trials than the national average, and many of the trials we offer are not available anywhere else on the West Coast. Today, I have the honor to introduce Dr. Walter Erba, the Chief Medical Officer of the Providence Cancer Institute, and he will share a few words of background about Providence Gynecologic Oncology Program and Clinic and its Medical Director, Dr. Christopher Darus. Hello, Dr. Erba.
Good morning and welcome to today's Providence Doc Talk. It's my pleasure to introduce my colleague and friend, Dr. Christopher Darus, who's actually the founding director, medical director of our Gynecological Oncology Program. Dr. Darus is a graduate of Wright State University School of Medicine in 2000, completed his residency in obstetrics and gynecology at the University of Colorado Health Sciences Center in 2004. Following completion of his residency, he performed a fellowship in gynecological oncology at the University of Virginia in 2007. This rigorous training prepared Dr. Darus for the advanced surgical and medical treatment techniques that are required for his patients with gynecologic malignancies. And he practiced this art at the Maine Medical Center since 2007, where he was, in addition to the leading physician, he was the director of the research program. He had a joint appointment at Tufts University in Boston, where he was involved in education and training of the next generation of fellows. We were fortunate to recruit him in 2020. COVID, difficult recruitment, difficult move for all. But Topher has been very active. He's built a wonderful GYN oncology program serving our patients. As perhaps he'll tell us about the two young physicians that he's added to the program over the past year. And he's done great work, continues to do great work. And Dr. Darus, we look forward to your remarks this morning. Thank you.
Thank you, Dr. Erba, for that lovely introduction. I'm going to talk mostly today about ovarian cancer and endometrial cancer, and I talk about it going different directions because we're seeing some changes in both of these cancers. So today we're going to talk a little bit about us, about our group. We're going to talk briefly about clinical trials, and then we're going to focus the rest of the talk on both endometrial cancer and ovarian cancer. So I think it's important to define what is a gynecologic oncologist. There aren't a lot of us out there, so there's sometimes some confusion about what we do and what we don't do. But I think this is the best definition I've seen from the Society of Gynecologic Oncology, and this says that the gynecologic oncologist serves as the captain of a woman's gynecologic care team. So we follow patients all through their journey. We are surgeons. We give chemotherapy and systemic therapy, and we do surveillance on patients. So why are we important? What can we do to help? And for ovarian cancer, this has been looked at in numerous studies all throughout the world, and a number of studies done here in the US. And what most of them, if not all of them, show that For ovarian cancer, survival rates and outcomes are improved when patients are cared for by a gynecologist versus another type of physician. This is particularly evident with surgeries that are performed. We're much more likely to completely remove ovarian tumors, and 80% of patients who have surgery by non-gynecologic oncologists have inadequate surgery. And then also for cancers of the uterus, like endometrial cancer, we do a better job surgically staging the patients. There's less surgical complications and less unnecessary additional treatment like radiation therapy. So 2 years ago, we started this program here at Providence Cancer Institute. We have 2 clinics. The mothership, so to speak, is at Providence Portland, opened almost exactly 2 years ago. And then for about a year, we've also had a satellite clinic at Providence St. Vincent's on the west side. This is from day one. The vision of this program has always been to be a clinical trial oriented program that would allow patients to have access to the state-of-the-art clinical trials. We, as surgeons, we perform all of the appropriate radical surgery. We do a lot of minimally invasive, including robotic surgery. As folks who treat patients with systemic therapy, we also have access to and give patients all the appropriate targeted therapies, immunotherapy, and chemotherapies based on their individual situation. We have really outstanding and invested group of radiation oncologists at both sites, and they're really important partners for us. And we are really fortunate to have 2 fellowship-trained gynecologic pathologists who ensure that we get the right diagnosis for patients. All of these folks are part of our tumor boards, which review all the patients, and we come up with a multidisciplinary care plan. So this is our group of providers. I like to say that we have 3 physicians, but 5 doctors, because both of our nurse practitioners, June Ma and Nora Lersch, both have doctorate degrees. And then, as far as the physicians go, aside from myself, Sandy Nemi has been in town for a number of years, and we're thrilled that she joined us in the beginning. And then Netta Julia, shown here, recently joined us a couple of months ago from Southern California, and she's already making an impact. So about 2 years ago, we started this program, and I was really excited to join such an amazing cancer program that is responsible for the care of 1/3 of the cancer patients in the state of Oregon. We're tightly aligned with the Earl Charles Research Institute, which some of you know about, which is an amazing community-based research institute with over 200 researchers, led by Dr. Erba, who just spoke to you a few minutes ago, who's really set the tone for this being a world-class research facility in a community environment. So just talking about clinical trials very briefly, when we look at clinical trials, there's 4 phases of trials. We don't really do much of the phase 4. Those are a little bit different, but looking at the first phase 3, the first 3 phases of trials, phase 1 trials are really focused on first in human or brand new agents or new combinations of drugs. And these are small studies. These are for patients who really want kind of the brand new stuff that's out there, and we do a lot of that here. Phase 2 trials are more focused on, is this an active agent? Is this something that we can potentially use to change the standard of care? And phase 3 trials are those larger studies that compare the investigational drug to what's already established, and that's how we get FDA approvals. So already, after just 2 years, we already have the most clinical trials open to gynecologic cancer patients in the state of Oregon. We currently have open for enrollment 6 ovarian cancer trials, 5 endometrial cancer trials, and 5 or 6 other studies that are being developed now that'll be open within the next 6 months as well. We also have over 40 phase 1 trials, and these are studies that can enroll patients with a number of different cancers, including gynecologic cancer. So talking about What is gynecologic cancer? These are cancers that start in the female reproductive tract. So, going from most common to least common, cancers of the uterus, or the main part of the uterus called the uterine body or the uterine corpus, are almost always cancers of the endometrium, which is the internal lining of the uterus. The next most common are cancers of the ovary, and we now know that most of what we've called ovarian cancer for many years, much of it actually starts in the fallopian tube. So these two cancers are kind of lumped together nowadays. Cervical cancer starts in the lower part of the uterus, and these are in fact the most common cancers in women, or the most common gynecologic cancers in women worldwide. But 85% of those diagnoses are in developing or resource-poor countries. Fortunately, in the US, cervical cancer rates have been plummeting, and we hope to continue to see that. We also see patients with more rare cancers like vulvar cancer and vaginal cancer. So I do have a few surgery pictures. Hopefully there are not too many gross ones, but this is one that I think is important. So this is kind of a normal pelvis. And what we see here, if we're looking in the pelvis, we see the colon back here. This is the uterus, the outside of the uterus. And on both sides, we have ovaries and fallopian tube. So if there's a cancer of the ovary or fallopian tube, it's generally on the surface and it's exposed to the inside of the abdomen. And that tells us a lot about how it spreads. Whereas cancers of the uterus are usually of the endometrium, which is inside the uterus. So looking at the top 10 diagnoses by cancer site in women, the National Cancer Institute each year puts out this list, and this top row are new cases, and this bottom row are deaths from these cancers, and these are the top 10s. And here I have comparing today, 2022, to 10 years ago, 2012. Breast cancer is still the most common cancer, and it probably will be for a while. But if we look specifically at gynecologic cancers, so cancers of the uterine corpus, which again are usually endometrial cancer, are here at the fourth most common cancer in females. But we've seen a significant increase in cancers of the uterus over the last 10 years. And in fact, if we go back 20, 25 years, there's even more. When I was in medical school in the mid to late 90s, this was more like 38,000, and now it's almost 66,000 cases a year. If we look at deaths from uterine cancer, it's even a little more alarming, because the rates increased by 50% in the last 10 years, from 8,000 to now over 12,000 deaths this year from this cancer. If we look at ovarian cancer, we see a different story. So there's a slowly decreasing trend in new diagnoses from 10 years ago, 22,000, to now we're not even in the top 10. Fortunately, we're down here about 20,000 cases a year, still too many, but it's decreasing slowly. And in terms of deaths, it was the fifth most common cause of cancer death in women 10 years ago, with 15,500. It's still the fifth most common cause of death, but there's fewer deaths. There's under 13,000. And what is alarming to us also is that uterine cancer is almost now kind of caught up to ovarian cancer in terms of cancer deaths, and it will probably surpass ovarian cancer for the next couple of years. So we're going to start by kind of doing a deep dive on cancers of the endometrium. And this, again, is the most common gynecologic cancer in the US and other developed countries. About 66,000 cases this year alone, and it's been increasing, as I said, for a while. It will soon surpass colon cancer as the third most common cancer in females. And once again, this cancer starts on the internal lining of the uterus. So the good thing about that is that it often has symptoms, and it's often bleeding. So because it starts inside the uterus, a lot of women who have this, or even have the precursor to this, will have abnormal bleeding. So the take-home message is any spotting or bleeding, even tiny pink discharge after menopause, is abnormal. It doesn't mean there's cancer, but it means that there needs to be an evaluation. It's a little harder diagnosis to make in women before menopause, but typically we see irregular or abnormal periods, sometimes very heavy, sometimes bleeding between periods, sometimes unusual discharge. And although PAPs are not designed to pick up uterine cancer, sometimes we will kind of just get lucky and we'll have an abnormal PAP that is suggestive of a potential problem not in the cervix, but up here in this part of the uterus. So we're going to talk about these two types of endometrial cancer in a little bit more detail. So I want to make sure this is clear. This is kind of old school thinking, but it's still very relevant today, is that there's basically two different types. There's a what we call type 1, and that's about 80%. And that's associated with patients who are often obese, who have diabetes, and estrogen excess. Why do they have estrogen excess? Because fat cells make estrogen, and that can stimulate the uterus to grow, especially the endometrium, and it can ultimately turn into a cancer. The other type that is not associated with estrogen excess is type 2. That's only about 20%. However, these are much more aggressive cancers. They occur in women who are older. They're unfortunately much more common in Black women. There's a definite racial disparity here, and we see a lot more of these in Black women, and we don't know why. And again, they're much more aggressive. So in terms of the type 1, obesity is the major risk factor for this cancer. And some of you have seen these maps from the CDC, and these go back to the 90s. And we see that there's an obesity problem in the US and in many countries in the world. So back in 2012, there was no state in the US that had more than 35% of their population that was considered obese. Now, in this situation, which was just last year, we see some states that have obesity rates of up to 50% of their population. So this is correlated with the increasing rates of endometrial cancer. If we look at those a number of other countries around the world, there's a very similar story. So this was looked at a few years ago in 26 of 43 countries. There's been increased endometrial cancer rates. Now, if we look at the other type, the type 2, the more aggressive type, we are definitely seeing a big problem with racial disparities with this cancer, especially in non-Hispanic Black women in the US. And we're seeing rates that are as much as 3 times as higher as Hispanic women and non-Hispanic white women. And the rate of death is actually now double that in non-Hispanic Black women compared to white women. And this is a really important thing to study. It's been recognized by the government as something that's very important for us to unravel this. And a lot of groups are looking into this now, and hopefully we'll have some answers, and we can decrease this terrible rate of climb here. So in general, the good news about endometrial cancer is most women will present at an early stage, which means confined to the uterus, so about 2/3. And when they present at an early stage, they can do really well. And about 95% of women with stage 1 endometrial cancer will still be alive in 5 years. So this speaks to the importance of early diagnosis. This cancer is primarily managed surgically, and I think the biggest advances in the last 10 to 15 years have been with surgery. The basic surgery for this is a hysterectomy, so removal of the entire uterus and typically the fallopian tubes and ovaries, except for very young women. And then we also take out lymph nodes that can sometimes have cancer in them, and so that's the basic operation. And for many years, we did a very large incision, and this is actually was often very much larger than this one. Nowadays, most women with endometrial cancer have a minimally invasive surgery. Here in Providence, we do about 95% of these operations minimally invasively. So the patient has 3 to 5 small incisions, are about 8 millimeters each, and they go home usually the same day, sometimes the next morning. This is called this surgery is called laparoscopic surgery, and it's been compared to open surgery in a couple of very large studies done. And the end result is that the outcomes for the cancer were the same, but the patients did much better with laparoscopy. There was less pain, less bleeding, fewer surgical complications, and they often went home, like I said, the same day or the next day. So for laparoscopy, what we do is we put a camera into the abdomen. We put carbon dioxide gas in the abdomen, so we have room to work, and then the instruments are brought in as shown here to do the operation. Nowadays, most of these are being done with robotic assistance, and this is just a fancy tool that helps us do the operation better. The camera is three-dimensional, so we have depth perception, and the instruments actually have wrists on them, so we can move them around like they're our own hands. And this has led to us allowing to do this operation on a lot more women that we couldn't before. So the next major advance has been changing the way we take out lymph nodes. So for many years, we knew it was important to remove lymph nodes because you can't really see if they're positive. It's usually microscopic. So we have to remove the lymph nodes, and then the pathologist looks through all of that stuff under the microscope to find the needle in the haystack. Because if there is spread to the lymph nodes, there's still an opportunity to cure that patient with additional treatment like radiation and sometimes also chemotherapy. But the problem with that is that we would see this phenomenon of lymphedema, and this is a pretty significant case, and it isn't always this bad, but 30 to 40% of women who have all the pelvic lymph nodes removed can have lymphedema, so that's swelling in one of the legs here. And this is a chronic problem. It requires using compression hose, lymphedema physical therapy. It can be worse than this, actually. Usually it's not quite as bad as this, but it's still a big problem and a major quality of life issue, especially because so many of these women are cured and they have a long life ahead of them. So a few years ago, we started doing what's called Sentinel lymph node mapping. This concept was borrowed from melanoma, breast cancer. We've been doing this in vulvar cancer for a while as well. And so the basic idea is that when the patient is asleep, we can inject the cervix with a fluorescent or a medical dye. Typically nowadays, it's a fluorescent dye. And then that dye will travel through lymph channels that come out of the uterus, and it should stop at the first lymph node on the right and the first lymph node on the left. And we call that the sentinel lymph node, sentinel as if it's standing guard, because the lymph nodes are in a chain. So there's usually a first one, and that would be the one that if the cancer would have spread, it would go to that one first. And in our case, studies have shown about 97% of the time, we're going to pick up a cancer if it's in the first lymph node. So if it's not there, there's a very high chance that it won't be anywhere else. So instead of taking out 16 to 20 lymph nodes, now we're taking out 2 or 3. And that leads to much lower risks of lymphedema. It also leads to more accuracy because we're finding the most important lymph node. So this is an example of this. So this is a robotic surgery, and you can sort of see how the wristed instruments help, because we're able to turn our wrist to expose this area. These are very large blood vessels, and this is a lymph node right here. So this patient had already received the injection that day after she went to sleep on the operating table. And so we're looking here under normal light, and then we turn the infrared light on and we see a single sentinel lymph node there. These are lymph channels that are going to the node. So we take out this lymph node, and there's hopefully another one on the opposite side, and then that's it. So this has now become standard of care, and we're doing this pretty much on almost everybody. Okay. So moving on to treating advanced or recurrent endometrial cancer. So for many years, there's been a one-size-fits-all approach to this. And as we know, one-size-fits-all does not fit everyone. So looking at the old way we would do this is we would get tissue from the patient, and the pathologist would look at it under the microscope, and we get some information, and then the patient would get a one-size-fits-all chemotherapy typically. Nowadays, in the interest of heading towards personalized medicine, which means we give the right drug to the right patient at the right time, we want to know more information about the individual patient's cancer. And so we take tissue and we do very sophisticated molecular testing, including DNA sequencing. Almost all of this is done here at Providence, by the way. And based on that, we can understand what specific molecular features does a patient's cancer have that we can potentially exploit. And this is a little bit of a busy slide, but I mentioned before there's a type 1 and type 2 endometrial cancer. It's actually much more complicated than that. But when we look at a number of tumors, we have been able to segregate them into 4 separate types. And these are this blue, green, orange, and red type. And we can actually predict how a patient is going to do. This is survival until recurrence, and it's based on these 4 types. So these 4 types have different molecular features that we can exploit, and we're moving towards looking at doing trials to try to individualize treatment for each of these 4 types, and that's happening right now. Looking at one of these specific types called mismatch repair deficient, we know that this is about 30% of all endometrial cancers, and these patients often respond to immunotherapy drugs. And we have an FDA approval for this, actually. So talking a little bit about how this works, it's been, many of you have heard of pembrolizumab, or as it's called, Keytruda, or a drug called dostarlimab, or there's a number of them now. How do they work? Well, the T cell is kind of the workhorse of the immune system, and tumor cells can actually bind to the T cells and turn them off and say, I'm not the bad guy here. Well, drugs like Keytruda and others can break this bond, and then the T cell is free, and it kind of says, oh, wow, you are the bad guy. I'm going to attack you. So that's all well and good, but I think I think what I call the Scooby-Doo analogy is much better, actually. So many of you know Scooby-Doo, and there was always this nice man who they thought was just a friendly guy. But as you can see, when they took off his disguise, he was actually the bad guy. So this here is Keytruda, or the checkpoint inhibitor, taking off the mask and exposing the cancer for what it really is. And when it's exposed, you can then bring in these T cell cops to take the cancer away. So that's how they work. Looking a little bit more specifically, this is a study looking at specific molecular features of recurrent or advanced endometrial cancer. And, even going farther than those 4 colors that I showed you earlier, this is a study that we just opened. There's 5 arms, soon to be 7 arms in this trial. And all of these these patients are going to have their cancers looked at for these specific features, and they're going to get 2 drugs. They're going to get a checkpoint inhibitor like Keytruda, and then a second drug as well. So just again, the take-home message here is that abnormal bleeding is not normal, and we're all concerned about the increasing rates of endometrial cancer. So you can get the word out. Okay, so moving on to ovarian cancer. Ovarian cancer is a very heterogeneous disease. So a lot of different types of things that we call ovarian cancer. There's sort of 3 basic types. There's cancers that occur on the surface. These are called epithelial cancers. There's germ cell tumors that tend to occur in children and young women. And then there's sex cord stromal tumors. There's also a lot of cancers that can spread to the ovary, which could often confuse matters. We're going to just talk about by far the most common types of cancer in adult, or the most common types of ovarian cancer in adult women, and that is epithelial cancers. So these occur, as I mentioned earlier, on the surface of the ovary. And in fact, we now know that a lot of them actually start in the fallopian tube, because the fallopian tube is in close apposition to the ovary kind of grabs the cancers early. But because they are exposed to the abdomen, these little areas tend to flick off and exfoliate sort of, and set up shop in different parts of the abdomen on surfaces. And there's several different types of these cancers as well. So in general, we're seeing a slight or a moderate decrease in the cases that we see each year. And this light green line goes back from 1992 to 2019, and we see that cases, the rate per 100,000 persons is decreasing. And this dark green is the death rate. We're also seeing a decrease in death. Women are living longer with ovarian cancer. It's about 1 in 78 women will develop ovarian cancer. It used to be about 1 in 70, so that alone shows that we're slowly improving. The surgical stage is very important for treatment of these patients, and patients who have stage 1 cancers are unfortunately not common. This is confined to the ovaries. The most common stage we see is stage 3 and stage 4, and this is where it spreads to the abdomen or out of the abdomen to areas like the chest or inside of organs like the liver. And this is again because these cells can exfoliate off the surface and set up shop. So the basic operation for this is to kind of go where the cancer is, where we're not really operating on an organ per se, we're operating on a disease process, or we're operating on the cancer. So we go where the cancer goes. It's fairly common for us to see that even though the cancer started in the ovary or fallopian tube, that we see most of the actual disease in the omentum, which is a fat storage organ that hangs off the colon, because it's going to pick up all these exfoliated cancer cells. This is an example of what we call a omental cake, where we see a lot of the cancer in the omentum, and all this has to get removed. So again, we only find about 20%, 20 to 25% of patients ovarian cancer that's still in the ovary. Most of the time, we're finding it once it has spread. If we do find patients at a very early stage, the survival is outstanding. So stage 1 is about 90 to 95%. And we used to call this as the silent killer, and it's really until the last 10 years or so that we've understood that almost all of these women do have symptoms, but they're common symptoms for a lot of women who are in their 60s. So things like unexplained fatigue, weight loss, or even weight gain, bowel or bladder changes, increased abdominal girth, weight gain, feeling full easily. In terms of risk factors, the biggest ones for ovarian cancer are family history, especially if there's mutations in the BRCA genes. We'll talk about that in a few minutes. Things that decrease risk include pregnancy, breastfeeding, and use of oral contraceptives. So 5 years of taking oral contraceptives will reduce the risk about 50%. So the basic treatment for stage 3 and stage 4 ovarian cancer is a combination of surgery, and we call this a debulking surgery, and chemotherapy. And sometimes we do the surgery first, shown here, followed by all the chemotherapy, which is usually 6 treatments or 6 cycles. Sometimes we do half the chemotherapy first, and then we go and do the big surgery after that chemotherapy, and then give the other half afterwards. And we decide this based on both patient factors and tumor factors. And what I mean by that is sometimes the cancer is really taken over the patient, and they have a lot of flu in their belly, and their bowels aren't working, and they're not doing well. So we have to shrink the cancer to have a successful surgery. Sometimes the patient has a lot of medical issues that it's not maybe safe to do a big surgery immediately until we shrink the cancer. Other times we're looking at the cancer itself based on the examination, based on the CAT scan. There could be an overwhelming amount of disease there that we're not going to do well with the surgery without treating it with chemotherapy first. So then we in those situations, we typically will give some chemotherapy and then do the surgery. And for example, in these situations, this is looking up by the liver. These white dots are all areas of cancer spread. This is looking in the side of the abdomen, and all of these little dots are also areas of cancer spread. And they can sometimes coalesce to these plaques. So it's hard to remove all of these. It's impossible really to remove all of these little areas, typically, if they're all over the place. So chemotherapy can help eradicate a lot of those prior to the one big surgery. Just to look back at that initial picture I showed of a normal pelvis, uterus, fallopian tubes, ovaries, this is what it can look like with ovarian cancer, is that we see the uterus is here. This is the right fallopian tube, but it's all sort of buried in this gelatinous type cancer. And, so for this scenario, we definitely typically try to do the chemotherapy first. And what else can help with trying to make the chemotherapy work better so our surgery is successful? Because at the end of the day, what really matters is how much is removed at surgery. So the more cancer that is gone, the better the patient does. And that may seem intuitive, but it's not the case with every type of cancer. So we really want to debulk these patients down to very minimal disease and hopefully nothing visible. So what else can help? Well, the FDA is very excited by this drug. It's called Gen 1. And it's basically interleukin 12, which is a protein that's normally made by the immune system that helps kind of rev up the immune system. So we're now doing this study, and we're using this drug in combination with chemotherapy, and it's given directly into the abdomen through a port, right where the cancer is, to hopefully make the surgery more successful. So it's too early to know how this is going to turn out, but so far so good. Okay, so the good news here is that with good surgery and good chemotherapy, about 3/4 of patients with ovarian cancer, with advanced ovarian cancer, will achieve remission. And what does that mean? It means that there's no clinical evidence of the cancer, but often it's hiding and we can't tell it's there. In the case of ovarian cancer, about 70% of women who have remission will ultimately have a recurrence. So because of the very high rates of remission, but yet the very high rates of recurrence, it's really important for us to try to find a maintenance therapy that's safe and effective. And what does that mean? That's treatment given after all the chemo and surgery is done to try to keep the patient in remission and hopefully cure some patients or cure more patients. So this leads me to this slide, is that all patients with ovarian cancer should have genomic testing. And what does that mean? It means both testing for hereditary mutations that they could have inherited from one of their parents, like BRCA. We'll talk about that more in a minute. Also, testing of the tumor, that's called somatic testing, to look for mutations or alterations in the cancer itself that we can exploit, kind of like the example I gave earlier with endometrial cancer. So many have heard of the BRCA genes, and there's BRCA1 and BRCA2. These are responsible for this syndrome called hereditary breast and ovarian cancer syndrome. And about 15% of women with ovarian cancer will have a mutation in one of these two genes. And so again, the baseline risk of ovarian cancer in the US is it's actually a little lower than this now, it's about 1.2%. If you have a BRCA mutation, it's about 40%. A BRCA1 mutation is about 40%. BRCA2, it's about 15 to 20% risk up to age 80. So this leads me to a short video, and we're going to talk about a relatively new class of drug called PARP inhibitors. Let me see if I can get this to work. Somebody give me a thumbs up if this is if you can see and hear it. This is from Dana-Farber. Can you guys see that? So we're going to fast forward.
Every cell in our body is a machine, special function. And like machines everywhere, our cells sometimes suffer damage that interferes with their operation. One part of a cell that can be damaged is DNA, the genetic material that controls just about everything a cell does. Fortunately, cells have several mechanisms for making repairs. When both strands of the DNA molecule are damaged, normal cells use genes known as BRCA1 and BRCA2 to create proteins that help repair the breaks. Cancer cells also have ways of repairing damage to their DNA, which allows them to continue wreaking havoc within the body. In some cancer patients, however, mutations in the BRCA genes prevent the proteins from making repairs. Without repairs, damage would pile up to the point where DNA could no longer function and the cancer cells would die. But cancer cells have a second repair crew that specializes in fixing damaged DNA. The crew is led by proteins known as poly-ADP ribose polymerases, or PARPs. These repairs allow the cancer cells to remain alive and to grow and divide. Now, doctors have a new way of attacking such cells. Drugs known as PARP inhibitors can knock the PARP proteins out of commission. The loss of the PARP repair crew allows more and more damage to occur to the cancer cell's DNA. Eventually, the DNA becomes so damaged it's useless and the cancer cells die.
Okay. So I thought that was one of the best explanations of PARP inhibitors that I've seen. Okay, so just a few things about PARP inhibitors I think they're so important. So this is basically what the video was talking about, is that chemotherapy can damage DNA of the tumor. If the tumor has this BRCA pathway intact, it can fix its own DNA. And all of this together, so the BRCA genes and some of the helper proteins along with BRCA. This system is called HRD, or homologous recombination. So about half of all ovarian cancers show a problem with homologous recombination. And some of that's from BRCA and some of that's from other causes. Okay, as I said, about 15% of patients will have a BRCA1 or 2 mutation. Another 10% will have a BRCA1 or 2 mutation just in the cancer itself. And so looking at PARP inhibitors, there's one called olaparib. And this was a very important study that we put patients on when I was in Maine years ago. This study has now been followed for a number of years, and we have a number of studies. This is probably the best one, though. So these are patients who have a BRCA1 or BRCA2 mutation, either hereditary or in the cancer itself. They underwent standard surgery and standard chemotherapy, and then they were given this drug olaparib, also called Lynparza, for 2 years. And what we're seeing is that if they received the drug versus if they did not receive the drug, there's a significant benefit in the patients not having a recurrence. So at 5 years, 48% of the patients had not had a recurrence, while only 21% of the patients who got placebo did not have a recurrence. So really impressive, frankly, amazing benefit. And they only got it for 2 years. So even after they stopped taking it, there was this benefit that's prolonged. Statisticians talk about flattening of the curve, and we think a lot of these patients are going to end up being cured, frankly. If we look at 7-year follow-up, and this, I just saw this 2 weeks ago. This hasn't even been published yet, but this was just presented at a meeting I was at 2 weeks ago. This is just looking at people who are still alive. Now, some of these women may have had recurrences of their cancer, but they're still able to be treated for a long time after that, typically. 2/3 of the patients at 7 years who took olaparib were still alive, whereas only just under half of the ones who took placebo were. So the risk of death was decreased by 45% in those patients. So this is really amazing. So now this is our treatment paradigm that I showed before. Now, some patients are going to also qualify for maintenance therapy. This is actually FDA approved for patients with BRCA mutations, also patients who just have HRD, which means there's some mechanism in BRCA that is messed up. But it's also approved for those who don't have HRD, the other 50%. The outcomes are not as great, but they still do seem to, it still does seem to help. So I'm just going to end on this slide, and this is a slide that gives me a lot of optimism. In the years between 2014 and 2020, there were more drug approvals for ovarian cancer than there was in the 60 years prior to that combined. So in summary, talk about both ovarian cancer and endometrial cancer. We see that in ovarian cancer, patients are living longer. In endometrial cancer, rates are rapidly increasing, as are rates of deaths. We see significant racial disparities with endometrial cancer that we don't fully understand. The big advances with endometrial cancer in the last 10 years have been improvement in surgery. And now we're looking at improvement in treatments for patients with advanced endometrial cancer. And for ovarian cancer, we're very excited with PARP inhibitors, and they clearly are going to play a very important role in keeping patients in remission for hopefully a long time, and hopefully improve the cure rate as well.
Thank you so much, Dr. Darus. That was fascinating. And I was a particular fan of your Scooby-Doo analogy with the T-cell cops. I think that is something that can explain a large amount of what we do at Providence Cancer Institute and our immunological research. We do have a couple of questions that would be great for us to answer in our remaining 10 minutes. The first one is there anything new regarding clear cell carcinoma of the uterus? Any new research there?
Yeah, so clear cell cancers of the uterus are quite rare. Clear cell cancers of the ovary look very similar. They're also relatively uncommon. It's about 8% of ovarian cancers are clear cell. We know they're very different. They're molecularly very different. In fact, if you look at their genes, they look more like kidney cancer clear cell cancers than ovarian cancer clear cells. So the hope is that we could treat some of these cancers like we did with some of the advances in treating kidney cancers. Unfortunately, that didn't work. So those studies were done 5 to 10 years ago, and they didn't work. So now we're looking at other approaches specifically for clear cell. We just completed a trial that included clear cell patients. It was a national study sponsored by the National Cancer Institute. We just finished it like 2 months ago, and so I think it's been recognized that clear cells are a different entity, and we should be looking at them differently. So there are trials that are going to be looking at those specifically.
Great, thank you. And then the next question, I know you touched on this briefly when you were talking about the different types of cancer, but why is obesity such a risk factor, and how does obesity factor into these types of cancers?
Yeah, so obesity is a risk factor for a number of cancers, but not all. But the cancer that's most obesity related is endometrial cancer. Why? Because estrogen, which is a female hormone, is made in fat cells, and it can, the lining of the uterus or the endometrium is stimulated to grow by estrogen, and its growth is kept intact by the other female hormone, progesterone. So if there's this relative imbalance of too much estrogen and not enough progesterone, the lining of the uterus can kind of grow in an uncontrolled fashion. And as it gets thicker and thicker, it can become abnormal and become cancerous. So that's why we see this problem with a direct relationship between obesity and endometrial cancer.
A third question that was proposed may be a specific question, and somebody was curious about how new protocols may conflict with somebody with a history of multiple sclerosis. Have you come across that in your clinical care research?
Well, I mean, there's I think that may relate to some autoimmune issues, and in general, we can't really use immunotherapy with patients who have autoimmune disease, at least traditional immunotherapy, because it stimulates the immune system and it can make the autoimmune disease worse. So that may be what the person's getting here.
Okay, thank you.
Yeah.
As the inaugural medical director of the new Gynecologic Cancer Program, what are your goals for growing the program, and how can philanthropy help?
Yeah, so I think that we really want to be a research-oriented gynecologic cancer program. We've been getting referrals from other gynecologic oncologists in the region for our clinical trials, and we hope to sort of be that clinical trial beacon. So I would, and I think eventually we're going to start doing more translational or like laboratory research that works with all of those great researchers that we have in the Charles Institute that can help help us figure out some new treatments that we can get to patients and start doing our own trials as well. Also, I hope to reach more patients in different parts of the state who may have difficulty with transportation. I just saw a patient virtually recently who lived way in southern Oregon and wanted to come up for a trial, but she just couldn't swing it because of the cost involved. So we're always looking for help in that regard as well.
Extending care throughout the state of Oregon has always been so important to Providence. So that's wonderful to hear. Well, thank you so much, Dr. Darus. If you were inspired by today's presentation and you would like to get involved and learn how to help, please feel free to contact me. My information is on the screen, and we will be sending a follow-up email in coming days. Today's talk is the last one of our 2022 Providence Doc Talk virtual speaker series. Watch for more information in the spring on our 2023 series, and thank you again for joining us. Have a wonderful afternoon.
So I see there's a question that just came up also. I think it's a very important question. I'd like to answer that. So the question is, do any studies involve quality of life as an endpoint? Absolutely. That's extremely important. And I think pretty much all of the National Cancer Institute sponsored trials and many of the other trials as well, especially if they're phase 3 trials, we have to have quality of life as an endpoint. And we've been doing that for a while now. And oftentimes we are surprised that more aggressive treatments do not decrease quality of life. So, so that's really important, because if the patient's quality of life is poor, that's not a good endpoint. So, so I think that's a really important point that person raised.
Thank you for catching that. I didn't see that.
All right.
I will make it one final ask then. Are there any further questions before we wrap up for today? Wonderful. Well, thank you all for attending. Dr. Darus and myself will stick around in case anybody does have any further questions. Thank you so much. Have a great afternoon.